Hello, everybody. Welcome to the latest IMS webinar, Primary Prevention of Cardiovascular Disease with MHT, Where Are We Now? Thank you very much for attending. We have two fantastic speakers for us this afternoon. We're having a few technical problems with Bob Langer in Florida, so we are going to start with Howard Hodis. The plan is to do the two presentations one after the other, and then we'll have plenty of time for questions afterwards. If you could please make sure you put your questions in the Q&A function, then we will try and go through them at the end of the session and answer as many questions as possible. I'd just like to start introducing the two speakers. Dr. Howard Hodis, Professor Howard Hodis is the Harry J. H. Bauer and Dorothy Bauer Rawlins Professor of Cardiology, Professor of Medicine and Population and Public Health Sciences in the School of Medicine, Professor of Molecular Pharmacology and Toxicology in the School of Pharmacy, and Director of the Atherosclerosis Research Unit at the University of Southern California in Los Angeles. Professor Robert Langer is the Principal Scientist and Medical Director of the Jackson Hole Center for Preventive Medicine and Emeritus Professor of Family Medicine and Public Health at the University of California, San Diego School of Medicine. He's a member of the board of the International Menopause Society and a member of the board of the Foundation for Healthy Aging. He's an epidemiologist, family physician, and preventative medicine specialist with more than 40 years' experience as a primary care physician and more than 30 years of experience in research on cardiovascular disease and many other areas. So we are blessed with two extremely good speakers today, and without further ado, I just want to get the ball rolling and start with Professor Hodis. Before we do that, I just need to state that this webinar is supported by an unrestricted educational grant from BESANS, but confirm that they've had absolutely no role in the selection of topics, the speakers, or any of the content. Thank you.
So as you're all aware, cardiovascular disease is the #1 cause of death in women, causing more than half of all deaths. Compared to the other causes, you can see breast cancer right here in this little sliver at about 4%. Cardiovascular disease and death mainly occurs in postmenopausal women, as you can see here, versus premenopausal women. Therefore, is a extremely great risk for women as they transition into menopause. So perhaps one of the shocking revelations was that for decades we understood that women who selected hormone replacement therapy had significant reduction in cardiovascular disease, anywhere from 20 to 60% across approximately 40 to 50 epidemiological studies shown for decades. WHI and other randomized trials actually showed a null effect of women randomized to hormone therapy versus placebo. But it was clear that these randomized trials included a very different population of women versus observational studies. Here is a summary of perhaps the most important demographics of these two populations. Randomized trials showed women who had an average age of over 63. Observational studies included young women between 30 and 55. Women in randomized trials were on average more than 10 years past menopause. And in observational studies, women were very close to the time of menopause when selecting hormone replacement therapy. Flushing was excluded in randomized trials. It was felt that it would unblind women to the randomization. In observational studies, it was the predominant reason why women selected hormone replacement therapy. And duration of therapy was much shorter in randomized trials, less than 7 years, observational studies for decades. And weight also was an important factor, which I won't speak much to today. So these kind of data, randomized trials, observational studies, and their juxtaposition to each other, arterial imaging, randomized trials, and animal studies all came together and formed what we call the timing hypothesis, which basically states that the effects of menopausal hormone replacement therapy on atherosclerosis and clinical events are dependent upon when hormone replacement therapy is initiated in relation to menopause and/or age. So these data are quite evident at least the support for this hypothesis is quite evident. This is the first meta-analysis to really look at this issue, which the Salpeter group looked across all ages, and this is more than 20 randomized controlled trials put together, and they showed no significant effect of randomization hormone therapy versus placebo. Women more than 10 years past menopause or greater than 60 years of age, again, no treatment effect shown. But all that treatment effect that we'd seen in observational studies was obvious in women who were randomized in these studies less than 10 years since menopause or less than 60 years of age. Now, these data were paralleled very nicely by all-cause mortality, where we see the same pattern where all the treatment effect or reduction in all-cause mortality is in the younger women who were initiated on hormone therapy. In this case, it was women with an average age of 54. And as I showed you earlier, in observational studies, these data were evident. The reduction in coronary heart disease was evident in women typically initiating hormone therapy less than age 55. This meta-analysis by Salpeter was more recently confirmed by the Cochrane systemic review meta-analysis. And as you can see again, women who were randomized more than 10 years past menopause or greater than 60 years of age showed no effect on coronary heart disease or on all-cause mortality. All the treatment effect, again, was down in the women who were randomized less than 60 years of age or within 10 years of menopause. Significant reductions in coronary heart disease and again in all-cause mortality, about a 30% reduction. Perhaps the closest test to the estrogen hypothesis derived from observational studies comes from the Danish osteoporosis prevention study. In this study, women were closest to menopause when randomized. In this case, they were on average only 7 months past menopause. And as you can see, after 10 years of randomization, women who received hormone therapy versus placebo had a statistically significant effect at 10 years of intervention, which was maintained out to 16 years. And again, perhaps this cohort of women was the closest representation we have to those women from observational studies. Now, ELITE is the only randomized trial to test, formally and specifically test the hormone replacement therapy timing hypothesis. It was a 2x2 factorial design where women were randomized who were more than 10 years past menopause and women who were within 6 years of menopause. As you can see in the 10 or more year strata, women had a average of 14.5 years since menopause. They were on average 64.5 years. You can see there was no significant treatment effect. Now, this is on atherosclerosis, which was determined by carotid artery wall thickening. All the treatment effect, again, was down in the women who were randomized who were less than 6 years from menopause. Indeed, the average year since menopause was 3.6 years, and the age was 55.4 years. And you can see really the dramatic difference in the time since menopause and the age and when these women were randomized to the trial. And it was in these women where there was a highly significant treatment effect in the reduction or the slowing down of progression of atherosclerosis. Here's the placebo group, and then here's the treatment group. And the difference between these two groups was, as you can see in the P for interaction, highly statistically significant. So very strong support for the timing hypothesis. When we take all the data and put it together in one figure in this forest plot, here's a summation of the observational studies, approximately 40 of them. You can see that the risk estimate, point estimate, about 36% reduction in coronary heart disease in women who selected hormone therapy versus those who did not. And we take the women from the meta-analyses and from DOPS, those women who were randomized less than 60 years of age or within 10 years of menopause. You can see again a highly consistent treatment effect, highly consistent with the observational studies, with significant reduction in coronary heart disease versus placebo or no treatment. Now, these are meta-analyses that are a summation, obviously, of many studies. So I took a look at the literature just to look at the treatment effects, since the top part of the title is what's the best hormone therapy. And this is the best we can really take from these meta-analyses. And this is a relative scale. So in other words, we had 1 to 15 ratio in these studies that I looked at in terms of oral CE plus or minus MPA versus estradiol valerate, transdermal oral MPA, and vaginal estriol. And in between these two extremes, some of the studies were oral 17 beta with plus or minus MPA and oral progesterone, or oral 17 beta and or esterone acetate. So clearly the greatest contribution in terms of hormone therapy to these data is with oral CE plus or minus medroxyprogesterone acetate. Just to give you an idea of the hormone therapies that were used in these studies that were included in the meta-analyses. So let's take a look at mortality. Obviously, a very important concept or outcome when we deal with primary prevention of cardiovascular disease. And this is really important in women because what we've learned over the years is that, for example, with lipid-lowering therapy as one of the primary prevention therapies, is there is absolutely no effect on all-cause mortality, whether it's primary or secondary prevention in women. This is true for just about every other primary prevention we use in women. Here's an example of aspirin. I just chose one meta-analysis from many trials of aspirin now that have been reported. It's true for ACE inhibitors and other primary prevention therapies that we use in women. Now, there's quite a bit of observational data showing the effect of hormone replacement therapy on mortality outcomes. I chose here the Finnish study out of the Nicola group because it has the Finnish registries, one of the best death registries we have to look at. And here you can see that there's a consistent reduction in coronary heart disease mortality, whether we look at any therapy, estradiol or estradiol plus progesterone. Everything is less than 1. Here's the time durations. This is also true for stroke mortality. I know you've heard a lot about stroke, but based on what we see here, as well as other observational studies, again, with the selection of hormone therapy, women show a reduction in stroke mortality. And as you would expect, since cardiovascular disease is the #1 cause of all-cause mortality indeed is also reduced when looking at the data from the Finnish death registry. Now, there is also a consistent reduction, a lot of numbers, I apologize for that. The arrows are the important part of this table, because as we look across WHI and all the meta-analyses that have looked at coronary heart or cardiovascular disease mortality, all show pretty much a consistent reduction in all-cause mortality. Observational studies show about a 20 to 60% reduction in all-cause mortality in women who selected hormone therapy. And that's approximately where we see the randomized trial data, anywhere between 20 and 60%. Now, this is another meta-analysis. This is a Bayesian meta-analysis looking at randomized controlled trials and prospective observational studies. And what this demonstrates very nicely is the very similar reduction in all-cause mortality with the use of hormone replacement therapy. Because WHI is the largest data set we have to look at outcomes, especially mortality, where you need large numbers. I'm going to show you some of these data. This is the most recent data from 2017 that looked at a variety of mortality out of WHI. As you can see, all-cause mortality is reduced when the two trials of E plus P and E alone are combined. There's a significant reduction. There's a reduction in cardiovascular disease mortality. There's a reduction in all cancer mortality, and all other mortality is significantly reduced. 2020, WHI published their breast cancer mortality. We can see that there was no treatment or no effect on mortality with E plus P. It's not significant. However, about a 40% reduction in breast cancer mortality with the use of conjugated estrogen alone, and this is statistically significant. This is with almost a 21-year follow-up. Also, interestingly, out of WHI, mortality due to Alzheimer's disease and dementia, combining both trials, is statistically significantly reduced. Again, this is the 2017 data from JAMA. You can see that the effect is statistically significantly reduced in E alone, and there's, again, a null effect in the E plus P in terms of mortality on Alzheimer's disease and or dementia. So I just want to show this slide, I think, again, it's pretty indicative of the overall literature. This is from WHI. It's looking at the E alone trial, the E plus P trial. Most of the important, prominent outcomes are shown on the x-axis here. What's highlighted, according to the WHO designation of drug frequency reactions, is the rare level, which is about 10 per 10,000 women. And I think you can see across both trials that really the only thing that approaches exceeding the rare level is deep vein thrombosis in the E plus P trial. All the other outcomes in terms of the adverse outcomes are statistically non-significant in the group of women who were initiated in hormone therapy less than 60 years of age or within 10 years of menopause. And again, deep vein thrombosis in the E plus P trial was the only statistically significant adverse outcome among all these different outcomes across both trials. I just want to summarize that cardiovascular disease is the #1 cause of death in women, and postmenopausal women are at an increased risk for cardiovascular disease. In fact, across the entire age range, a postmenopausal woman has anywhere between a 2 to 6-fold greater risk for cardiovascular disease than does a premenopausal woman. And that's Framingham data from decades ago, I think about 30 years ago, that data was reported. The data strongly support a reduced all-cause mortality and coronary heart disease when hormone replacement therapy is initiated in women less than 60 years of age or within 10 years of menopause. Compared with placebo, risk associated with HRT are statistically non-significant, less than 1 per 1,000 or 10 per 10,000 women, especially in women less than 60 years of age and or within 10 years of menopause. Hormone replacement therapy reduces all-cause mortality, cancer mortality, which includes breast mortality, other mortalities, Alzheimer's disease, dementia, coronary heart disease, and new onset diabetes, which there's no time really to discuss. In addition, hormone replacement therapy prevents bone fractures in an unselected population of women and is also the most effective therapy for significantly reducing menopausal symptoms. And there's now a much growing literature showing that avoidance of hormone replacement therapy, specifically estrogen therapy, in postmenopausal women aged 50 to 59 results in increased disease conditions and mortality, and these immense personal and societal economic consequences. So menopausal HRT is a cost-effective, sex-specific therapy. It reduces all-cause mortality, heart disease, bone fracture, new onset diabetes, with rare risk when initiated in women around the time of menopause and continued long-term. Therefore, the benefits of HRT outweigh the risk when initiated around the time of menopause. And like always, in everything we do in prevention and any medication we use, everything needs to be individualized to each specific case of each patient. Thank you. I appreciate your attention.
Thank you very much indeed, Professor Hodis. Welcome back. We're ready to go with your presentation.
Thank you, Professor Hillard, and thanks everyone for joining us today. As Dr. Hodis said, cardiovascular diseases are the leading cause of death in women, in fact, leading cause of death worldwide. And in women, that burden is increasing as life expectancy increases in less developed countries and as women worldwide live an increasing proportion of their lives beyond menopause. Coronary heart disease, or CHD, accounts for the majority of deaths attributable to cardiovascular diseases. The Women's Health Initiative, or WHI, was and remains the largest clinical trial ever conducted to assess the effects of menopausal hormone therapy, or MHT. And the primary stipulated outcome of the WHI hormone trials was CHD. WHI results have had a profound effect on the use of MHT since the abrupt early terminations of the first arm in 2002 and the second in 2004. As one of the original WHI principal investigators, I believe that the results have been distorted and misrepresented so that most clinicians have a mistaken idea of the findings, especially those related to CHD and breast cancer. A frank look at the data shows that the WHI was a well-designed, well-conducted study with a treasure trove of knowledge, but much of it was distorted in publications and some key findings were ignored or barely mentioned. Hence my title today, Where the WHI Went Wrong and What It Got Right. I have no conflicts to declare. And it's important that you understand that the opinions I will express are mine. They should not be taken as representing those of other WHI investigators or the views of the WHI program office. And here you see a nice aerial shot of where this work was conducted by my staff at University of California, San Diego. So I think it's timely and appropriate to pay respect and thanks to the Golden Girls, the last of whom, Betty White, died just 2.5 weeks ago on New Year's Eve at the age of 99. The Golden Girls were the primary spokeswomen for the WHI in the recruitment stage, and they helped us to achieve the extraordinary feat of enrolling over 160,000 women into the WHI. Of those, nearly 27,500 were randomized into the hormone trials. The three overlapping trials, hormones, diet, and calcium vitamin D, and the MHT trials viewed independently are unprecedented and unrivaled in magnitude and duration as clinical trials specifically involving menopausal women. The primary study period ran from 1993 to 2005. And so how did we get the notion that MHT could prevent cardiovascular diseases? These data are from the first important observational study of cardiovascular diseases, the Framingham Heart Study, and show differences in the incidence of cardiovascular events in 20-year follow-up of just about 3,000 women during the 1950s and 1960s, comparing women who were premenopausal to those who were postmenopausal within 5-year age groups. In each group, premenopausal status was associated with a strikingly lower rate of cardiovascular disease, suggesting that premenopausal hormone levels might be protective. In the 1960s through the early 1970s, most MHT was conjugated equine estrogen alone, CEE alone, at a dose of 1.25 milligrams daily. Early observational studies evaluating that experience looked at the incidence of cardiovascular disease in women who used and didn't use estrogen. And these studies here in the purple bar found a roughly 50% lower rate of cardiovascular disease among users compared to non-users. But the use of unopposed estrogen in women with the uterus stopped abruptly in the latter 1970s when a clear link was established between that mode of therapy and endometrial cancer. So after a steep drop in use for a few years, adding a progestogen for 10 to 12 days per cycle was shown to prevent endometrial hyperplasia and cancer. And with that, MHT use slowly regained traction in the 1980s. studies looking at outcomes in that new era of MHT. I hope I am still online. Something just dropped off.
Yes, you are, Professor Langer, no problem.
Okay, all right, thank you. Studies assessing that new form of MHT in the early 1990s still showed a benefit, but that benefit was reduced to about 25 to 30% rather than the 50% seen earlier with high-dose unopposed estrogen. Also of great importance in considering these data, the women in these studies almost always started on hormones to treat menopausal symptoms at the time of menopausal transition. Starting a woman many years into menopause on hormones was far outside practice norms. In addition to the consistent data from observational studies, animal data also supported the idea that estrogen-based MHT could protect against cardiovascular disease. Tom Clarkson at Wake Forest University pioneered the use of a monkey model to simulate the metabolic and physiological effects of hormones in women. Those primates were overectomized and then fed an atherogenic diet for about 2 years to create a substrate of atheroma in their coronary vessels that could mimic the expected condition of the vessels in typical American menopausal women. Dr. Clarkson's group conducted a number of long-term clinical trials in monkeys, testing treatments that were or could be used in women. This slide summarizes 2 separate trials, one outlined in blue, comparing placebo, CEE alone, and CEE plus MPA, and another outlined in magenta, comparing placebo, estradiol, and estradiol plus progesterone. The overall designs were essentially identical. All monkeys were overectomized, fed an atherogenic diet for 2 years. Then the atherogenic diet was continued, and some monkeys remained untreated as controls. Others were given one of the treatments. The endpoint was the extent of atheroma in the coronary arteries after 30 months. First, on this slide, it's clear to see that both CEE and estradiol provided significant protection against atheroma. However, in the trial of CEE plus MPA, the MPA largely attenuated the benefit of the CEE. In contrast, in the trial of estradiol plus estradiol and progesterone, there was essentially no attenuation by progesterone. The observational data in women and these experimental data in non-human primates set the stage for the postmenopausal estrogen progestins interventions trial, or PEPI. It was the first major clinical trial in women sponsored by the National Heart, Lung, and Blood Institute of the NIH. And I was fortunate to co-author the study proposal for the University of California, San Diego with Dr. Elizabeth Barrett-Connor. Our proposal was successful. Dr. Barrett-Connor, who was very well known in the field, became the national study chair, while I became the study director at UCSD. And conducted between 1989 and 1993, PEPI randomized 875 women between the ages of 50 and 64 to 4 active MHT regimens or placebo for 3 years at 7 clinical centers. Primary outcomes were lipids, insulin glucose, coagulation factors, and blood pressure. Treatments were placebo and 4 CEE-based regimens, CEE alone, or with cyclical micronized progesterone, or with cyclical MPA, or with continuous MPA. It was the first trial of continuous MPA anywhere, and the first North American trial of micronized progesterone. When the results overall showed that all of these forms of MHT approved the cardiovascular intermediates that we studied, it was taken as proof of concept to plan the hormone trials for the WHI. This slide shows the results of my calculations using the combined effects of the risk factors that we studied in PEPI on projected 10-year risk of incident cardiovascular events using standard modeling equations. While all regimens were better than placebo, CEE plus MPA, either cyclical or continuous, was associated with the smallest projected benefit, about a 6% reduction. CEE plus micronized progesterone was associated with more than 3 times greater protection, and CEE alone was still better at more than 4 times greater projected protection than CEE plus MPA. I presented these results to the WHI steering committee in 1993 in hopes of having CEE plus micronized progesterone added to the treatments. I failed in that effort because the only safety data for endometrial protection with micronized progesterone were from PEPI, which had tested a cyclical regimen. WHI program office had decided that they wanted only continuous regimens due to concerns that breakthrough bleeding might reduce treatment adherence. So the WHI was planned in the early 1990s to test prevention of CHD by MHT in women who were well past menopause. It was built on data I briefly summarized, reflecting initiation in newly menopausal women with long-term use, primarily of high-dose unopposed estrogen, along with a few studies reflecting CEE 0.625 milligrams and cyclical MPA, together with emerging findings from PEPI, all suggesting that MHT could prevent major age-related diseases, especially cardiovascular disease and fractures. The data in recently menopausal women were so strong and consistent that most experts believed a trial in that age group was not necessary. That led the US Congress to request expert review to advise whether to continue funding WHI when it barely started. The fact that the WHI was to test the effect at older ages was key to its value and further supported by the observation that in cardiovascular trials, treatment benefits were usually greatest in those with a higher burden of disease factors. So to be clear, WHI MHT trial was designed to test the benefit of contemporary in 1993 MHT for the prevention of CHD, the dominant chronic disease in postmenopausal women, with stroke and fractures as additional outcomes and breast cancer as a safety outcome in older women who are at greater risk of these diseases than the younger women who were represented in the prior studies. To achieve that goal, the WHI recruitment was restricted within age strata. Only 10% of the cohort was to be aged 50 to 74. Another 18% were aged 50 to 59, so that only 30% of the cohort was below the age of 60. Fully 70% were aged 60 to 79. The average age was 63, and on average, a WHI woman was 12 years postmenopausal. This statement from the WHI protocol shows that the plan was to randomize 27,500 women who would take MHT for 9 years for the desired statistical power, and the monitoring plan expected crossover to CHD benefit at about 6 years. Instead, the WHI CEE plus MPA arm was stopped at just over 5 years on the recommendation of the Data Safety and Monitoring Committee for a persistent early increase in cardiovascular events, much of it not CHD, but venous thromboembolic disease, a breast cancer rate crossing a time-weighted monitoring boundary, not a statistically significant finding of harm, and a composite global index of all outcomes that did not support benefit. The CEE plus MPA arm was not stopped for an outcome. It was stopped for futility. And suddenly, everything that had come before was swept away as though the WHI had reinvented the entire field of menopausal hormones. Overnight, supposedly, the truth was revealed. Women were told that they had been misled. Now, the paper that turned the world upside down was drafted by a small group from the Coordinating Center and Program Office without any participation by the principal investigators conducting the study. It was accepted and put into galley before being shown to the principal investigators on whose behalf it was written. It was shown for the first time to the full group of PIs roughly 10 days before the planned release, and changes that several of us requested immediately as soon as we saw and had the opportunity to read the manuscript to bring the text in line with the data could not be made because the journal issue had actually already been printed. And an inflammatory and misleading press release was also presented promoting a non-significant finding of increased breast cancer. Requests to correct that were also refused. So the stunning news spread like wildfire across the world with headlines like major hormone study stopped for breast cancer harm, pandering to women's greatest fear despite statistically non-significant results. The paper was published in 2002, many years before EPUB ahead of print, and the press release was issued 9 days before the paper was expected to be delivered to journal subscribers. So clinicians and epidemiologists who could have put the paper in perspective were bypassed. Doctors treating menopausal women didn't have access to the paper to interpret the results for themselves before their patients began calling frantically. And science was vetted via the press with a focus on non-significant findings that played on women's greatest fear. In fact, that firestorm was the desired outcome. Interviewed in 2017, the primary author of the 2002 paper said, quote, "The writing group knew the paper and press release would provoke a strong reaction, proportional to the size of the dogma it overturned." Even the title of the first paper was misleading. It used the words estrogen plus progestin, implying a class effect for the findings, when in fact it reported on only a single regimen, CEE plus continuous MPA. And the press had a field day. This sold lots of newspapers, lots of magazines. Here, Newsweek says a new study raises fears about the risks for millions of women, and they went on to assert that they knew what women should do. Inevitably, the use of MHT plummeted steeply worldwide. The results in that paper were not presented per protocol. It focused on nominal, unadjusted results with minor mention of results that were only adjusted for multiple endpoints and multiple looks at the data. There was no adjustment for covariates. The nominal results here suggest some harm for CHD and stroke, venous thromboembolic events, and not quite harm for breast cancer, along with benefits for colon cancer, hip fracture, and total fracture. Here in yellow, the results adjusted only for multiple outcomes and multiple looks, not covariates, are significant for harm only from venous thromboembolic events and benefit against fractures. In contrast to the expected 6-year interval that was anticipated to detect changes in CHD outcomes, in the CEE plus MPA trial, there was an increase in CHD in the first year with a decreasing trend over time. That was an important clue to the clinical meaning of the WHI, but not addressed in the WHI reports. Actually, this mirrored the surprising finding of the heart and estrogen replacement study, HERS, a secondary prevention trial of CEE and MPA in women with known cardiovascular disease that reported its results a few years before the stopping of the CEE plus MPA arm in the WHI, but while that arm was continuing. HERS here found an increased risk of CVD events in the first year, followed by a decreasing trend over time for an overall null result. And really, true to the best principles of science, the WHI provided valuable insights that were not anticipated in the trial design. CHD trends were attributable to age-related differences in the pathophysiology of atheromatous plaque that were unrecognized prior to the HERS and WHI. WHI and studies since have helped us to learn that organs with estrogen receptors respond differently to estrogen supplementation after a long period of low estrogen levels than they do when early replacement preserves physiologic estrogen functions. These are some of the WHI's most important contributions to clinical science, but not discussed in WHI papers. The most damaging of the WHI's errors with regard to cardiovascular disease was the inappropriate generalization of the overall findings to younger menopausal women. The initial and subsequent papers failed to acknowledge that the trials were not designed to study outcomes in recently menopausal women. Only 12% of the cohort was less than 55 years old, the group usually prescribed MHT. Instead, the press release said, quote, "The adverse effects of estrogen plus progestin applied to all women, irrespective of age." Even though the trial wasn't statistically powered to assess effects in younger women, exploratory analyses were consistent with prior published literature. And here you can see that for women within 10 years of menopause, there was a non-significant reduction in CHD that was gone in women more than 10 years postmenopausal. And similarly, in women aged 50 to 59 with vasomotor symptoms, there was a non-significant reduced risk of CHD. Because the number of recently menopausal women in WHI was small, a group of investigators with access to the Nurses' Health Study and the WHI combined those populations to conduct an analysis of CHD outcomes with CEE plus MPA, stratified on initiation within 10 years of menopause or more than 10 years after menopause. On the left, you can see that at about 6 years, just as we had predicted in planning the WHI, there was a crossover to benefit. However, on the right side, you can see that there is never any crossover to benefit for women starting 10 years or more after menopause. 2 years after the early termination of the CEE plus MPA arm, the CEE alone arm in women with hysterectomy before they enrolled was stopped early. This time, the reason was a persistent increase in stroke. And actually, to the consternation of the leadership, many of the findings in the CEE alone arm were opposite of the trends in the CEE plus MPA arm. Although the CEE alone trial was stopped for an increase in stroke, that increase was not present in women 50 to 59. Major contrasts in the results for CEE alone versus CEE plus MPA included a reduced rate of breast cancer on the cusp of significance when the study was stopped, and a non-significant reduction in CHD. Later papers found reduced CHD in women 50 to 59 when revascularization was included, reduced coronary artery calcium in women 50 to 59, and reduced breast cancer overall in longer follow-up. These detailed results show the stepwise gradient for CHD prevention by age, suggesting a strong effect in women 50 to 59, even with the small numbers, just 30% of the cohort. And as you can see, there was no harm for stroke at these ages with identical numbers in placebo and CEE groups. And in this paper that focused specifically on CHD, Judy Shaw and I showed that if revascularization was included as a surrogate outcome for CHD, among women 50 to 59 on the far left, there was a 45% reduction in revascularization and 34% reductions in MI, coronary death, angioplasty, and significant angina. However, that protection was gone in women 60 to 69 and 70 to 79. As Dr. Hodis showed briefly before, a few years ago, the WHI published all-cause and cause-specific mortality findings for the intervention phase and 18-year follow-up. And in this figure for women aged 50 to 59 during the intervention phase, it's clear that all-cause mortality, and in general for all subtypes, women in this age group are less likely to die if they're using MHT. However, for women 60 to 69, those benefits are fading with no results in all categories. And for women 70 to 79, all outcomes move further towards harm. So where the WHI went wrong. Study publications have favored overturning what leadership called prior dogma at the expense of unbiased science. Most analyses have deviated from protocol in not adjusting for covariates. A focus on non-significant findings for breast cancer and publication before the paper could be properly vetted, both internally and externally, prevented rational discussion and swept away virtually all positive notions about MHT from 2002, continuing through today. There's been failure to acknowledge the fundamental question that drove the study design, a test of whether benefits consistently seen with MHT in women initiating near menopause would persist or perhaps be stronger in older women, and it wasn't. Instead, overall results were generalized to younger women, despite consistent peer-reviewed literature showing the opposite. There's also been failure to explore and explain the striking differences between the outcomes with CEE plus MPA and CEE alone. And what it got right, although not generally acknowledged by the WHI, it, together with the HERS study, gave rise to the concept of a window of opportunity for prevention of cardiovascular disease. It showed reduction in all-cause mortality with MHT for women aged 50 to 59. It showed that the progestogen is a critical modifier of estrogen benefits with CHD. And outside of cardiovascular disease, it showed clearly that MHT prevents fractures, even in women unselected for osteopenia. So this is a second opinion. At first, I thought you had something else. Thanks very much for your attention.
Thank you, Bob. That came across really well. So I'm pleased you finally got your connection sorted. Welcome back to Professor Hodis as well. Just a reminder, Q&A function, please use that for any questions. We've got a number of questions already in there, and we have about 15-20 minutes or so for questions. So I'm very happy to go straight to that. So thank you both speakers. The first question, which is I think repeated in some of the other questions, is really, Howard, you showed that WHI obviously with CEE. Can we extrapolate that data to estradiol, and how far can you extrapolate this type of data, both really with estrogen and also with the progestogen? And I know Bob's answered that to a certain extent, but I wondered from your perspective how you felt that could be extrapolated.
Right. So in terms of coronary heart disease, well, overall, as I showed, the majority of data is with CEE plus MPA, and that's in a variety of forms: unopposed CEE, sequential MPA, and continuous combined. But there have been, again, the second most use of agents has been estradiol, again, with and without MPA and progesterone. I know all the studies that we've done and other groups have been focused with estradiol, E2. And in terms of the atherosclerosis outcome that I showed in ELITE, that again was with estradiol. Many of the animal studies, as Dr. Langer just showed, have been also with estradiol. The Clarkson data is one of the exceptions, where he looked at both CE and E2, but a lot of CE. And again, the data look concordant. They look similar. There is perhaps a modifying effect according to the progestational agent that's used. That all still needs to be sorted out. In the shadow of WHI, we initially tried to look at the different common forms of progestational agents at the time. This is 20 years ago, but unfortunately never had that funded. So that does remain an open question. But overall, the data do look pretty consistent in terms of the effects on cardiovascular disease. Now, CEE does have perhaps some other additional benefits, if you will, than E2 alone. I think, for example, breast cancer. I think it's unequivocally clear, at least from the WHI data, that there is a reduction in breast cancer and also a reduction in breast cancer mortality, 40%. So that's something also that should be considered, I think, in making decisions about which form of hormone therapy to use.
So are you suggesting that one can't really extrapolate the breast cancer CEE data to estrogen alone? Right.
Well, I think again, it's difficult, but the data, at least with the other forms of hormone therapy, when you look at them in aggregate, aren't showing a large signal of breast cancer risk. But again, that C alone really does stand out, I think, as a pretty good signal.
Okay. So the second question, I think a lot of the earlier questions were for you, Howard, because obviously that you spoke first, but there's some increasing evidence of an increase in atrial fibrillation in the menopause transition. Can you comment on this and any evidence of HRT impact on that?
Yeah, so that's a good question. So we know that there is cellular instability, myocardial cellular instability through the transition. That is felt again to be due to ovarian hormone reduction. There's been some very nice studies done with calcium channel blockers in relation to, for example, angina during and early in the transition, and reduction in both angina as well as electrocardial dysfunction or instability. So again, this does appear to be perhaps a drop in estrogen and perhaps other ovarian hormones that can potentially be restored with replacement therapy. But again, there's not an extremely large amount of data, and that's another area that really needs to be more fully explored. And these are probably a different group of women also, I should say, because it's not all women that have this kind of outcome when they transition through menopause. I mean, obviously, the vast majority, we don't see electrophysiological problems in terms of myocardial function.
Okay, thank you. So the next question relates to your when you said in your presentation that there's one detail that confuses me. The question says, in the UK, the understanding is that dementia has overtaken cardiovascular disease as the #1 cause of female mortality. So is that not the case in the US?
As mortality?
Yeah.
Okay, I don't think so. I think cardiovascular disease still remains the #1 cause, at least in most of the westernized world. And as Bob said, in developing countries. And there's very good papers in the literature on this. So I don't think it's overcome the mortality. Now, it clearly is, I would say, as we continue to do studies in this arena with a newly funded trial, I think it's become a major concern of women. I think that's clear. And clearly there is a growing morbidity. I think that's undeniable. And women do appear to be at greater risk for this than do men. This being Alzheimer's and dementia. So I'm not clear about the mortality, though. I mean, I don't know specifically UK data, but I would think not. At least the last paper I saw in the worldwide causes of death.
Okay. So there's another question here, which I think is applicable to both of you, really.
I'm sorry, Tim. Let me just chime in on that, please. So in the WHI 18-year mortality data, one of the striking findings was that MHT actually reduced dementia mortality in the WHI women. So to the extent that that is a concern, once again, we have reasonably good evidence that MHT would be a strong preventive.
Okay, well, we can come back and speak more about that another time, but it's certainly very interesting. For both of you, I think the next question is about managed care, which is perhaps something more relevant to the US. In the present day era of managed care, how do you suggest clinicians individualize care? Do you have a quick algorithm that you can use or you can share?
That's a very tough question, in part because my experience with US managed care systems is that each of them is idiosyncratic in the way that they want to apply their guidelines. And on top of that, I continue to get these nasty notes from managed care and also insurance schemes that tell me that I am outside of clinical practice norms for continuing to prescribe HRT for my patients. So I think we still have a very long way to go to educate the decision makers, certainly in the US, as to the real uses, benefits, and risks of MHT. That said, again, the system is so idiosyncratic, I don't think I have an answer. Perhaps Professor Hodis does.
No, I think that's a great answer. And I would assume in most countries, a lot of decisions are really driven by cost, and that's a real big issue. If they can, any healthcare delivery system can hang their hat on a reason not to use a medication, and as Bob said, to receive letters consistently because we're using hormone therapy outside the norm, we're going to get them. And it just doesn't just occur with hormone replacement therapy, by the way.
Sure.
It's a pretty universal issue.
Okay, unfortunately, probably not going to solve that one this afternoon, but next question is just really more about the data that you've presented is largely with oral CEE. What about transdermal estradiol? Do we have enough data to be confident that that is going to give the same benefits? Howard, from your point of perspective?
So when you look at the meta-analyses, there's not a lot of transdermal studies that have been done. Phase is probably one of the larger randomized controlled trials is conducted out of the UK, in fact, and that was terminated around the time the WHI was, like a lot of trials, and that really didn't give us a lot of information, unfortunately. So it's very difficult to say, but again, everybody on this call knows better than I do. There is certainly a very important role that transdermal hormone therapy can play. One thing we do think is better with transdermal is not having an effect on venous thrombotic events. So again, it's in the armamentarium to individualize therapy for women. But again, there's no reason to believe that estradiol delivered transdermally has any more risk, if you will, than oral therapy, and perhaps does provide that benefit. We know that at least based on observational study, this is again out of the Finnish registry, that at least vaginal estradiol actually reduced mortality. So we know it's absorbed. We know that it does potentially have effects on outcomes.
Great. And sorry.
I'm sorry, I would chime in also that we do have consistent observational data for transdermal, for its benefits and for its lack of risk, especially on VTE, which again was the biggest harm in the WHI. Most of that data is from France and other countries that have really used much more transdermal, even over the last 2 decades or so. Unfortunately, in the post-WHI era, it's been almost impossible to get real significant funding for new trials of MHT. And as a result, the only trials that have been done for transdermal are too small to really draw conclusions.
Thank you. The next 2 questions, again, we're going on the same theme, but the aim of the presentation is to look at the optimal HRT combination for cardiovascular disease risk. So these 2 questions relate to progestogen, and I should add that a lot of the questioners are saying thank you both for such excellent presentations. So that's stated many times. So what about the levonorgestrel intrauterine system and the effects of that, and also a separate question about D56A containing preparations? So Howard, I don't know if you want to take that, or Bob.
I'll let Bob start with that one.
A lack of adequate data, really. I mean, we have just incidental reports, case reports, really, to my knowledge, no organized clinical trials that can.
Could you tell us what D56A containing preparations are? Is there a commercial preparation?
I'm not familiar with that.
No. So what about the levonorgestrel system?
Yes, that is commercially
Well, yeah, but the data
available as Again, to my knowledge, really just incidental reports, but no clinical trials have been conducted.
Anything else, Howard, from that one?
No, I think that's absolutely correct. It's really a lack of large data.
So further questionings, obviously based on the evidence that you've both presented about cardiovascular disease risk reduction, are there any particular screening tools you would use for women deciding whether they should take HRT for cardiovascular risk reduction, or should it be applicable just on age basis, or any other particular factors that you would look at?
Well, that's really a really great question. So we know that the underlying cause of clinical cardiovascular events is atherosclerosis. Really, it's atherothrombosis. So if we really wanted to be clear whether a woman was entering therapy in primary prevention, which does appear to be, let's say, the safest time, which then again is early, we probably would want to look at an atherosclerosis measure. Unfortunately, we don't really have any data to help guide us in that area. I think this is an important area that should be studied. But like Bob said, in the WHI post-era, that's unlikely that funding is going to come because this would require an extremely large number of women. So the best surrogate we have for that being underlying atherosclerosis and perhaps atherothrombotic risk, is really clinical symptoms, clinical events, which could be difficult because a lot of women, when they transition in early menopause, have chest pain complaints, which typically, or a lot of times, is non-cardiovascular, which those complaints typically do lead to workup, and then there is at least some evidence of it not being cardiovascular, such as stress testing, or they may go on to a minimally invasive coronary angiogram or even a CT scan, which again is not the best tool. Calcium is not the best tool for women early under the age of 50, especially. So really the best we have is looking at cardiovascular symptoms and any tests done to work up coronary heart disease complaints. So I think that's the best we can do at this moment in time. Most would suggest avoiding starting a woman on hormone therapy if she's already had cardiovascular events. But again, Bob showed some incredibly provocative data that we've known for a very long time and has never been pursued, unfortunately.
Let me chime in. I think as a basic approach, a cardiovascular risk assessment, including lipids and fasting blood sugar, hemoglobin A1C, and potentially, if there is a reason for concern, coronary artery calcium to understand what a woman's baseline cardiovascular risk might be. I personally am quite comfortable at the nexus between cardiovascular disease management and HRT. And so I will venture to put a woman who is sort of borderline there on HRT, but sometimes if I'm a little bit concerned about her cardiovascular risk, I will also start her prior to HRT on statins if they are appropriate for her. And there was some provocative data from hers suggesting that women who were already on statins when they started in that secondary prevention trial were quite well protected against coronary events, even in that first year with the CEE plus MPA. So I think that helps us, but again, you need a level of comfort with those different modalities in order to proceed that way. Again, I think if we have a relatively good idea that a woman doesn't have meaningful atheroma when we start, then it's an easy decision. it becomes increasingly more complicated depending upon the other risk factors. And unfortunately, at least where I practice, we can't rely on the cardiologists or other internists to help us in that assessment because they uniformly think that HRT is poison. And so we're kind of stuck there.
On that point, there's several questions on the theme, Bob, the fact that you've done a fantastic service by sort of exposing what happened in the WHI and the history of it, which is fascinating listening to and reading. So several of the questions say, why does the misapplication of the WHI data persist, despite the fact that it's been clearly shown to some of it to be erroneously portraying for younger women? What has been done to reverse the damage of standard of care? And is anyone planning to take out a lawsuit against them?
Oh, interesting. Why does it persist? I think we have to go back to Andy Warhol's 15 Minutes of Fame. The absolutely stunning and sadly brilliantly executed hatchet job on HRT with the initial press release and the way that the news just spread worldwide like wildfire in a way that almost no other news other than some major world events has spread in the last several decades, I think set an almost impossible bar to overcome. And when you had opinion leaders like Time Magazine, Newsweek, most of the major newspapers, all telling women that they had been misled and that this stuff was awful, and particularly pandering to the fear of breast cancer, which is clearly women's greatest health concern in every survey that we look at, it was, again, almost impossible to overcome. And even the striking contrasting results for CEE alone hardly made a wrinkle in the perspective, not even among clinicians, yet alone women, where there was protection against breast cancer and in general, no harm for CHD, and in fact, long-term benefit for CHD. So it's been very, very difficult to overcome that. Lord knows I've tried in writing and in talk and lots of other venues quite a bit, and I know increasingly there are others and in fact organizations now trying to set this straight, and certainly the IMS has done that consistently with our recommendations over the last many years. I would challenge everybody who is listening to this webinar to try to go out and talk to your peers, and where you can influence your healthcare systems to turn this around. As one other example of it, the U.S. Preventive Services Task Force, which is highly influential in the U.S. and in Canada with regard to recommendations for disease management, repeated their position back about 3 years ago that MHT should not be used for primary prevention of cardiovascular disease. And I, along with Dr. Hodis, Dr. Sorrell, many other leaders in the field, actually wrote a rebuttal to that, sent it to that task force. They did not acknowledge it, but then we published that in both climacteric and menopause, again, trying to get the information out there to the practicing clinician population, that the impressions of MHT are just dramatically incorrect. Again, I challenge everybody on this webinar to see what they can do to try and challenge those notions.
And any prospect of any more formal challenge, or do you think it's too late?
Well, I think the institution that fomented this still does not want to recognize the problems that they caused. So we still have, in terms of the WHI, really virtually no publications and no acknowledgement of what I presented as likely the real value of the study, instead standing on harm. And with that, we still have other federal agencies in the United States supporting that position, with the black box warning from the FDA on all estrogen containing menopausal prescriptions and so on. So no, and you can't sue Uncle Sam. So in answer to that question, no, we're out of luck.
Okay, that's great. We're coming towards the end of this, but there's still a few questions coming through. Again, so I'm trying to pick out the themes of the questions. So what about the old, Howard, what about sort of starting the benefit risk of starting HRT in someone, say, over 60? A couple of questions about concern about destabilizing plaques. Is there any evidence that you can still start it at that, given that they might have missed the window of opportunity?
I think it's more difficult, but I think, as Dr. Langer pointed out, looking at potential risk factors and weighing that against the need for hormone therapy, and justifying it that way is one way to go. I wouldn't say it's an absolute no. A lot of women obviously have missed the window, continue to miss the window. A lot of women were stopped inappropriately, and still perhaps require therapy. And I think that's probably the best way to go, is individualizing the hormone therapy to each woman that comes to you and asks for it.
Okay.
Let me chime in as well. I think first it's important to recognize that there's not an absolute threshold when a woman turns 60. This is relative to a woman's time of menopause and really what her endogenous estrogen levels have been before she might start on HRT. And in addition, I think with careful selection and potentially, again, with pre-treatment with statins for a woman whose risk might be questionable, one can start MHT after the age of 60, and I have done that quite often in my practice. But I think it really depends on your assessment of how postmenopausal she is. In other words, what her exposure to estrogen has been recently, and what her likely level of atheroma is. And then potentially with stabilizing plaque with the effects of statins, if you have questions. But again, that's not an area for the timid. You would really need to have some comfort in your assessments.
A question about, maybe one of you can answer this, just very specifically about that, about women with elevated lipoprotein(a) levels, because hers suggested some benefit, even in older women.
So Lp(a) is a very difficult lipoprotein to control. Now, let me just say that yes, there's observational data that does support a potential risk from this lipoprotein particle. There's good treatment data that shows, however, that a way to mitigate that risk is reducing LDL cholesterol. So there's a lot of focus on Lp(a), but there's very little, actually no data supporting that reducing Lp(a) reduces cardiovascular disease. In fact, most of it is supported by reducing LDL cholesterol. With that said, estrogen is one of the major ways to lower, or does have one of the major effects on Lp(a) and lowering it. There are other agents that are now become available, and there's specific agents being developed which are small molecules to specifically reduce Lp(a). So good studies will follow. We will understand it better. But estrogen it does have a pretty consistent effect in lowering Lp(a). It is one of the few drugs we have to lower it. So if that's your inclination and that's going to be your indication, then again, as I said earlier, I think it's individualizing the therapy. And as Bob has eloquently stated, looking at all the different risk factors and your comfort level in starting the medication.
Thank you. Well, thank you both for that. I'm going to ask one final question, Bob. Again, it's one that's come through a few times. Is there any possible way of assessing or putting a number on the degree of harm and mortality that the misrepresentation of the WHI has caused? I know there were a few studies initially about that, but anything more updated on that?
Really not that I'm aware of. I think it's a very difficult thing to assess. Dr. Sorrell published a very nice paper on that 5 or 6 years or so ago, particularly in women who'd had hysterectomy, where in fact there should be absolutely no question that breast cancer would be an issue for at least CEE, because in that WHI study, there was a reduction in breast cancer. But there have been studies like that. Again, I think the Sorrell paper really stands out for it. I'm not aware of anything new. And in fact, as I mentioned at the beginning of my talk, it's increasingly hard to estimate the effect because as women in developing countries go increasingly through menopause and those populations grow, and as women's survival overall to older ages increases, I think that the potential benefits of HRT, not just for cardiovascular disease protection, but also for fractures, which are a huge issue, is not being had by a huge proportion of women worldwide. And that degree of morbidity, let alone mortality, is impossible to assess. We can get estimates. I wrote a paper published in Climacteric last year that looked at that against the World Health Organization data for various chronic diseases in women. But again, to get anything other than a rough estimate, I think is impossible.
Okay. So I think we should draw things to a close there. Thank you all, both speakers, very much for excellent presentations and answering so many questions. And thank you to all the participants for joining us, particularly those who put in questions. I'm sorry if we haven't particularly addressed your question, but we've hopefully covered the major thread of all the questions. So it only leaves me to thank you all very much for your time. I just want to finish by reminding everybody of the International Menopause Society meeting, which is going to be, thank you, on the 26th, 29th of October this year. It is intended as a live event, so we're looking forward to seeing as many of you possible there, but there will be connections as well for those if you can't make it live. And there's a suitable placed aeroplane there just showing you that you can get there. So we look forward to seeing you all in October, and there'll be further webinars throughout the year, and your details will be posted to you. So thank you very much for your attention.